started, and where is your question? Right, so if you have read and understood, considering it critical care scenario, can you tell me how are you going to manage this patient?
Yes, as regards this patient, I will manage this patient according to CRISP protocol in form of ABCD approach.
Yes.
This patient will be managed according this case, which is post-TURP syndrome. As regard the airway, if the airway is critical and the patient is drowsy as present in the stem, I will consider intubation of the patient, especially if the glaucoma scale is less 8. Otherwise, the patient will be managed in HDU or ITU according to the organ failure or the status of the patient. After that, the patient will, if there is ongoing still irrigation, but the patient in the recovery, I will stop any irrigation. The patient also will be managed according to the blood pressure. If the blood pressure is hyper, I will give furosemide as the loop diuretics. And also the patient will support the patient in form of exposure control hypothermia in form of the
Can you please
form
tell
of
me
the
why the patient might be confused or
Yes,
confused
as regards
patient?
confusion may be due to post-TURP syndrome, may be due to the anesthesia or the sedation, may be due to the blood loss, may be due to the cerebrovascular accident, may be due to hyponatremia due to delusional hyponatremic hypervolemia post-TURP syndrome. Yeah.
Okay, how can you tell me the mechanism how this confusion takes place?
Yes,
How this
as regard
confusion leads to cerebral edema?
yes, as regard the pattern of procedure, excessive wash with glycine, which is hypotonic, leading to during the TURP syndrome, leading to absorption of more glycine, leading to hypotonic hypervolemia, leading to edema at the expense of all tissue, including the cerebral edema. Another cause of confusion may be due to rather than cerebral edema, conversion of glycine into ammonia at the liver, leading to what's called ammoniacal encephalopathy.
All right. You said you'll use the diuretics furosemide. Why not thiazide?
Yes, as regards thiazide, thiazide is lead to potassium sparing. Is potassium is not potassium losing. Furosemide acts through in the sixth segment of loop of Henle, act by inhibition of sodium potassium ATPase. So the distal convoluted to end at the lobe of Henle. The distal convoluted tubule will lead to
what measures can be taken to prevent this TURP syndrome from happening?
Yes, to avoid the TURP syndrome, avoid excessive irrigation, and also close monitoring of the conscious level of the patient. So the patient must be referred to be done under spinal anesthesia to be the patient is aware. Also control electrolytes and EBG frequently measurement during the procedure.
Early intervention, regional and spinal anesthesia minimize OT time.
Yeah.
Yeah. Okay. Can you please tell me how would you define TURP syndrome?
Yes, this is hyponatremic, hypervolemic,
Bulimia.
delusional hyponatremic hypervolemia occurred due to excessive irrigation of hypotonic solution, which is glycine, rather than saline, which is isotonic, during TURP syndrome, transurethral resection of the prostate, leading to excessive absorption of this hypotonic solution, leading to delusional hyponatremia and the excessive edema along all tissue of the body.
What are the organs which can be affected by or due to TURP syndrome?
Cardiovascular system affected in form of hypertension, congestive heart failure, and pulmonary edema. Also, the brain, leading to cerebral edema. Also, the renal insult may occur, and also a metabolic disturbance in form of hyponatremia affecting the brain in form of cerebral edema. Yeah.
This TURP syndrome can be differentiated from what other conditions?
Yes, TURP syndrome must be differentiated other causes of confusion after the procedure as a cause of confusion must be differentiated from cerebrovascular accident, hypovolemic shock, hyponatremia itself only by presence of sodium less than 110, and the other causes in form of increased sedation or analgesia as morphine overdose.
What they use for irrigation?
What is the use of?
What is that they use for irrigation? What component or what compound is used
for what? I am sorry.
Irrigation.
Irrigation?
Yes.
Yes, glycine.
What
Due
is
to
glycine?
the effect. Yes, glycine is like sugar.
No, it's not sugar. It's simple amino acid, 1.5%. And then?
Use glycine as effective in using diathermy in TURP syndrome rather than isotonic, which is saline. Effective in diathermy transmission.
What is glycine?
I don't know. We can pass this
All
question.
right, and then come back to it later. All right, okay. Can you please tell me? All right, right. You told me
glycine is protein that can be converted in the liver into ammonia. Yes, it is amino acid converted in the liver into ammonia.
Yes. Okay. Right. Patient oxygen saturation is low. How would you manage that?
I will manage the patient. Yeah, it was high with 100% oxygen mask, and if the airway is not secure or edematous, I will intubate the patient.
All right. Are there any? Is there any fear of coagulopathy? This patient suffering from any type of coagulopathy? If yes, then what?
Coagulopathy must be differentiated from other causes of coagulopathy.
If this patient is susceptible to suffer from coagulopathy, if yes, then which one? And how would you prevent it?
I don't know. We can pass this
all right,
question.
Okay.
Yes.
Right. Why? All right. You told me patient. Okay, could have. Okay, this patient has. All right. What I wanted you to tell me, because you've read it, but you haven't read it in depth. I wanted you to tell me why the oxygen saturation is. You said you'll give 100%, but this is 88% with mask. So why this saturation is low?
Due to pulmonary edema.
Yeah. And tachypnea as well could be.
Yes.
Because it's recently operated. Yeah. Right. Okay. Yes. And the medical management of.
According to the medical management, the
Yes.
patient will receive the furosemide as a diuretic, and if the patient developed the hyponatremia less than 110, he will receive about 250 to 500 saline, 3%, but not more than 10 millimole per day of saline to be taken.
Okay, if patient develops cerebral edema, then
Yeah.
what would you suggest?
Yes, a diuretic in form of osmotic diuretic as mannitol.
Yes.
Yes, yes.
What is the mode of action or site of action of mannitol?
Yes, the
What
mode
does
of
it do?
action.
Yes.
Mode of action is osmosis.
Where? At PCT, loop-friendly, and collecting ducts. And what does it do? It inhibits the sodium and it causes water absorption. Okay, thank you. Started, and here is your question. Right, so if you have read and understood, considering the
Yes,
critical care scenario, kindly tell me how would you manage this patient?
I will manage this patient according to the critical care of surgical aeration protocol by
Yes.
maintaining patent airway, proper breathing, adequate circulation, and then I will do some blood tests for this patient, like complete blood count and urea electrolyte for the loss, and also and then and the group and the cross group and matching blood. Then I will insert an intravenous line and prepare for the fresh blood transfusions or fresh frozen plasma or platelets according to his blood result. And monitoring, start monitoring the patients with monitoring the blood pressure and urine output and central venous pressure. Also,
Okay.
assessment of the coagulation status, like prothrombin time and concentration and the platelet count. Then
What do you suspect? What has happened to the patient?
Yes, the patient is hepatitis C and alcoholic. He may develop the liver cirrhosis, and
Okay.
due to the alcohol, due to the as he is alcoholic and vomiting and has excessive vomiting, he may develop esophageal varices.
He may develop what? What?
Esophageal varices.
I can't understand. Okay. How would you differentiate it from the other conditions? Or what other conditions would you consider?
Yes, there may be other is there may be bleeding peptic ulcer,
Yes.
Mallory-Weiss syndrome,
Yes.
Mallory-Weiss
syndrome.
Perhaps syndrome, or
Yeah. Okay. Can you please tell me what is the pathogenesis behind this portal hypertension in chronic alcoholic patients, like this one?
Yes, the chronic alcoholism caused leading to cirrhosis.
Yes.
Chronic alcoholism causing the liver cirrhosis, which lead to more inflammations and adhesions inside the blood vessels, causing portal hypertension.
Yes, but there is more. You have to tell me all steps. It's not just causes inflammation and adhesion. It also leads to damage of the liver cells in fibrosis, and the nodular regeneration, and then this develops. Okay, this develops something, another condition, which is called or is responsible for several sites of portosystemic anastomosis. Can you name few?
Portosystemic anastomosis is there is at the lower esophageal anastomosis, the portal or the left gastric vein, and the systemic is the azygos. This is the lower esophageal. The upper anal, the portal is the superior rectal, and the systemic is the middle and inferior rectal.
Yes.
Umbilical portal is the ligamentum veins of ligamentum teres, and systemic is the superficial gastric. Also at the base area of the liver.
Yes, which site is involved here? Which vessels are involved in this case? What do you think?
At the lower esophageal.
Lower esophageal. Okay, good. Right. What would you do? What measures would you do to control the bleeding?
I will give the patient octreotide and vasopressin as a medical treatment. Yes. And there also injection sclerotherapy and bending, but not
yes.
more than 6 bends per session.
Yes.
And also tamponade using a meniscus tube.
If patient does not respond, then what invasive alternatives can you offer?
Yes, I will do portosystemic shunt, like
yes.
like spleen renal shunt, and also maybe stabbed esophageal resections. There will be the short gastric vein are ligated, and the distal esophagus is transected and reanastomosis above the cardia. Yes. Or the last option is the orthotopic liver transplant.
Very good. Okay. Can you please tell me, if this patient has anemia, what type of anemia do you suspect?
Microcytic hypochromic.
How would you manage that?
I will manage that by giving taking blood and group saving, and start assessment of the patient. By the cardiac index, blood pressure, and central venous pressure, and capillary fill, and give both wide bore cannula, 2 wide bore cannula, and start IV fluid. If there is by 1 liter, if no response, I will start the blood transfusion.
Okay, can you name few indications for platelet transfusion?
Of platelet?
Platelet transfusion, yes.
Yes, in this DIC, disseminated vascular coagulation, or any cause or other cause of thrombocytopenia, and DIC, platelet, DIC, and thrombocytopenia, and
okay, can you tell me some indications or usage of esophageal suction, Minnesota tube?
Indication?
Yes, please.
Yes, if there is esophageal varices,
yes.
Not relieved by medical or band ligation.
Yes.
If there is
can you tell me, according to the NICE guidelines, how is it inserted?
Yes, I will position the patient and elevate his head
yes.
on the bed over 45 degrees. Then I give anesthesia to the posterior pharynx of the patient, to the posterior pharynx and the nostrils. Then I will put a gel on the balloon, on the esophageal yes. balloon. I will pass the tube through the nostrils to at least 50 centimeters. Then I will start suction from the gastric and esophageal port. When the gastric balloon, this is for when the gastric balloon is correctly put in the stomach, I will start by inflating the balloon.
How much?
Around 500 milliliter, and then clamp the port, and then try to pull the tube back to assess there is a resistance. And then
balloon, how much would you inflate?
The esophageal balloon, I will inflate by sphygmomanometer around the 30 millimeter mercury.
Yeah, mercury, yes.
When the bleeding is controlled, I will reduce it by 5 millimeter mercury
Yes.
every 2 hours until reaching 25 millimeter mercury, and
Yes.
then keep it for around 24
How long?
hours,
12 to 24 hours.
and then deflate it by
Deflate it
5.
first. Yes, 5 minutes
deflate
per.
5 millimeters.
All right. Can you please tell me what are the risk factors or what are the complications of this procedure?
As maybe risk factor related to the tube, like misposition or causing skin necrosis or aspiration pneumonia,
Yes.
infection, sepsis.
Okay. Are there any contraindications when you should not insert the tube?
Yes, if contraindication, if there is
Recent oesophagogastric surgery, if there is
yes,
oesophageal stricture or oesophageal tear.
gel section or recent section. Okay.
Yes. Right. This patient can have thrombocytopenia. Can you tell me the causes? Why?
Causes of thrombocytopenia
In this patient.
yes, due to the liver affection leading to affection of the
Liver dysfunction, okay, and then
liver dysfunction, and also loss in blood.
yes,
And
yes, could be DIC.
yes, there.
Yeah. All right, bell has gone.
What?
Thank you. Bell went.
Okay.
Here is your question. Right. So if you have read and understood, considering the communication station, kindly begin.
Hi, I'm Mr. Azir, one of the orthopedic trainee working for Western Man today. Hi, sir. Can I confirm your name and age, please?
Hi. Yes, I am Muhammad, 40 years old.
Yes, nice to meet you. How can I help you today, please?
Yes, doctor, I am here to meet Mr. Man, the consultant. I have an operation today for my total knee replacement.
Yes, yes, I know that you are here today to do your knee
Sorry
operation.
for the arthroscopy, sorry.
Yeah, for your new operation, I know that, but I'm really sorry. I do apologize that our consultant, Mr. Man, has been called for an emergency case. So I'm really sorry to inform you that, but we will not be able today to carry out your any operation. I'm so sorry, man, sir.
Oh, how? I am here for this is it was postponed before. I need to call to Mr. Man now, please.
Yes, I do appreciate your fear and worries, but I'm really sorry to inform you you that Mr. Man has been called on an emergency case, so he will not be able to pick up any call. Um, uh, I'm sure that your knee is terrible and hurting you, but you must know that our protocol and in our hospital, any emergency case have to be prioritized and should rise before any operation. Um, I appreciate that you are frustrated, that I noticed from your notes that you have been postponed twice before, but it's out of our hands. Any emergency operation must be prioritized. How does that sound, sir?
Okay, so I need another consultant.
So, sir, I know that the choice of your consultant or your doctor is your right. But if you considered my point of view, I am fear that it will be time consuming, as the new consultant will study your case from the start. So it will be time consuming and will not be wise to study your case from the start. It will not be a benefit. So is that clear for you?
Okay, can you do this operation for me?
So as regard this request, uh, I appreciate that you are hurry to operate your needs, but it's not my authority to do this operation without supervision. I am still orthopedic trainee, and I am not eligible to do this operation. How does that sound?
Okay, give me an appointment now, please.
So, sir, I noted that you are still anxious and angry, but if you don't mind, can you take a seat, please, and be calm? As regard the exact next
Okay.
date for the operation theater, I couldn't give you now the exact next date. So we must to review all cases with our consultant and then post the next date for the ongoing list. But what I can promise you to emphasize and clear your circumstances, and you have been postponed twice before besides this one, and to put you in the next available date. And once we are ready to operate you, I will contact you as soon as possible. Uh, is that clear?
Okay, doctor, but now I have a problem with my job. How can my sick leave was finished, and I have problem with my employer now.
Yes, I consider that your fear about your job, but I can expand your sick leave and emphasize the cause why you will not be able to carry out your job as a postman. And if you want to contact your employer by myself to help you, I will be happy. No problem for me. Is that helpful for you, or are you in need to anything else?
Okay, so is there any complications for not doing the operation early?
So as regards this, it's expected that your knee is hurting or wearing for you, but you should be active as much as you can, but with non-weight bearing in form of swimming. I can arrange an appointment with a referral to the physiotherapist who is eligible and specialist in this program within time frame to strengthen your muscles around your knees will help you much more. Is that helpful for you, or you need anything else?
Okay, doctor, and regarding the analgesic, it is very painful to me. Can you prescribe? Do you have any other solution?
Yes, if you don't mind, can you tell me the name of your analgesic, please, to make sure that about
I
it?
think Finac, diclofenac, like this.
Yes, you are right that diclofenac has a side effect in form of GIT irritation or stomach ulceration. So we can substitute it with another one which is more safe on your GIT, especially your stomach or food reservoir. So I will prescribe another one for you, and I will also update Mr. Mann about this change. So you need anything else? Do you have any other question?
No, thanks, Doctor.
You'll go ahead and you'll complain. So you'll ask for the pulse.
So now I can sum up something. Make sure that we need to accept our sincerest apologize, please. It's not our issue. This is an emergency case. This is the one. The next one, the next available date for operation theater you will be updated once it is eligible or be updated. The third one, you will be substituted another analgesia rather than the diclofenac. Okay. Do you have any concern or any issue we can cover or help?
No, thanks.
Thank you.
Good. Thank you, both of you. Thank you. It's good.
Okay.
Started, and here is your question. Right. So if you have read and understood, considering
Yes.
the critical care scenario, kindly tell me how would you manage this patient?
Yes, the patient has a long history of non-steroidal anti-inflammatory drug
Yes.
and sudden severe pain, so most probably has ulcer, gastric ulcer. I will treat the patients according to the critical care of surgical irrigation protocol by maintaining patent airway, proper breathing, adequate circulation, and I will start the management of these patients by giving him a long-term proton pump inhibitor and antibiotic coverage. And also regarding the ulcer, maybe I will do a mental patch repair with the peritoneal toilet using intra-abdominal drain, also taking biopsy to rule out malignancy.
Okay. Regarding ulcer, where do you suspect that patient can have ulcer?
Where?
Where?
Yes, in gastric or duodenal.
Yes. So which wall of stomach? What
Which
is
wall?
most likely? Where in
Lower?
stomach? Yes, where in stomach it is most likely to perforate, and why?
Cardia?
You're not asking me, you're telling me.
No, I don't.
Okay, you'll read this more. Okay, can you please tell me, since patient has been taking non-steroidal anti-inflammatory drugs to relieve its pain, so what are the risk factors which are associated with it? Yes, please.
Maybe H. pylori infection, smoking, previous gastric surgery, steroids,
Yes.
and malignancy.
Okay, can you please tell me the pathophysiology, how this non-steroidal anti-inflammatory drugs causes peptic ulceration?
Yes, it has a direct toxic and affecting effect on the epithelium, the gastric epithelium. It's also block the barrier, it causes impairment of the barrier properties of the gastric mucosa.
Yes.
And also it release the suppression of the of the gastric release of prostaglandin, which is important, which is an important barrier of stomach, and also reduction of the gastric mucosa blood flow and interference with the repair of any superficial injury.
All right, you talked about mental patch repair. How is it done? Can you please tell?
After good rehydration of the patient and the antibiotic coverage, it will be we will do a mental repair and good peritoneal toilet.
Okay. In case of perforated gastric ulcer, what is the best option of management?
The best options is biopsy.
Very good. To rule out malignancy. All right, very good. Can you tell me, what is the action of hydrochloric acid?
Yes, the action of hydrochloric acid is the activation of pepsinogen to active form of pepsin, which has a role in proteolysis. Also, it has an antimicrobial mechanism, antimicrobial action. It stimulates the duodenum, in the small intestine to release the cholecystokinin and secretin, and also stimulates the gastric absorption of calcium and iron.
Can you tell me about the phases of gastric secretion? How would you categorize them? Yes, please.
Yes, first is the cephalic phase, in which there is a receptor for satiety and the stimulus and the smells. There is caused stimulation of the cerebral cortex, impulse to the cerebral cortex, then to the medulla, then to the parasympathetic impulse action, leading to vagus stimulation of the vagus stimulation, leading to stimulation of the gastric phase. In the gastric phase, there will be gastrin release. Sorry.
No. Okay.
There will be gastric phase. There is a small there is a stretch receptor detect the distension of the stomach, and the chemoreceptor, which detects the increased pH of gastric juice, leading to increased gastric emptying, going to the intestinal phase, in which the stretch receptor detects the distension of the duodenum, and the chemoreceptor detects the increase detect the fatty acid and the glucose in the duodenum, leading to the endocrine cell secrete cholecystokinin and secretin, which has a negative feedback effect on the gastric phase secretion.
Very good. Considering that patient can have perforated gastric ulcer or duodenal ulcer, perforated duodenal ulcer, what are the differences in their management?
Gastric or duodenal?
Yes. How would the management differ? How would it be different if patient has gastric perforated ulcer or duodenal perforated ulcer? What would be the difference in management?
Can we conduct these questions
at the end? Okay. All right. Considering that this patient had chest X-ray done and showed gas under the diaphragm, what does this signify?
The air under this is indicating perforated viscous.
Perforated viscous. Okay. Can you help me to read this X-ray?
Yes, it is a plain. It is a plain X-ray, adequate with showing the ribs. So it is an adequate, and the spine is barely seen. There is an air under. There is air under the frame, indicating a perforated disc.
Okay. Can you please tell me, considering the criteria, when would you place this patient for operation theater listing?
For what?
What is that listing called?
Sorry, place the patient for what?
For operation theater, for OT listing. Patient maybe needs surgical management. Just
yes, if he developed peritonitis.
Yes, but there is a name of special category or classification list.
Yes, yes, needs to be classification.
Yes.
As the patient, as the priority for the operation, it is urgent.
Yes. Okay.
So the priority for has the priority for the operation.
So it has.
But after the
urgent
emergency,
priority.
no,
Yes,
it is not. It is urgent after the emergency, like
or immediate. Okay.
emergency is aortic rupture or
Tell me
splenic
about the
rupture.
listing. How is it categorized?
Yes. Categorized first is the emergency, in which has high risk for the patients for the life of the patient, like aortic
Can
rupture.
you give some examples?
Aortic rupture, splenic rupture.
Yes, or abdominal aortic aneurysm rupture. Okay.
Yes, aneurysm, and then the urgent, which has a risk for the patients, but not immediate, and can be can be managed within.
Can you give some examples of priority?
Like appendicitis or perforated
No, not
gastric.
appendicitis, like the reduction of closed or fixation of the fractures.
Yes.
Okay, and then at the end, these are the elective ones, which could be any primary joint replacement, etc. Right.
Yes, then the priority and the elective.
Yes. Okay.
So appendectomy is not urgent?
Appendicectomy is in urgent. Appendicectomy, not
Is
in
urgent.
priority. Yes, please. Urgent.
Okay.
Yeah. Okay, good. Thank you.
Thanks. So.
And here is your question. Right, so if you've read and understood, considering that history taking station, kindly begin.
Yes. Hi, I'm Mr. Azin, one of surgical Dr. Zaid. Can I confirm your name and age, please?
Dr. Hamdi, are you there?
Yes, I am Jane, 19 years old.
Nice to meet you, Jane. How can I help you today, please?
Yes, doctor, I have severe tummy pain.
So I'm really sorry for that. Must be stressful for you. But if you don't mind, can I ask you some question regarding your issue, besides taking notes while I am talking to you? Do you agree with this?
Okay.
Don't worry, it's gonna be too confidential. So are you in need to any analgesia to prescribe now?
No, that's okay.
So when did it start? Firstly, this pain, please.
Yes, it was coming and go, but now it's severe, very severe.
Yes. Come and go and severe. Can you rate out this pain, please, out of 10, considering 10 is the most severe?
Yes, 10.
10, okay. What's its look like, please?
It's colicky.
Colicky, yeah. Can you point at the site of the pain, please? Where is it?
Yes, right here.
Where?
And it's in all my tummy.
In all your tummy. Okay. So when did it start? Firstly, when did it first notice this pain?
Yes, it's just today. It becomes severe, and so I came to the hospital.
Yeah, sorry for that. Have you had this pain like this before?
No.
Anything making else? Have you noticed anything making it better?
Um, by yes, by passing stool.
Okay. So anything making it worse?
No,
No. So is it related to a special food or special position?
no,
Okay. Is it only with passing stool?
no. It's all the time.
All the time.
Not
So
related.
yeah. So have you noticed that any change in your bowel habits?
Yes, I know there is the diarrhea.
Okay. What is the color?
No, no, I didn't notice. Normal.
Okay. How many times do you go to the toilet per day?
3 to 4 times.
3 to 4 times. Yeah. Excuse me, Ms. Jane. As regarded the pain, did it move anywhere else?
Yes, to my back.
Do you, is it relieved on leaning forward?
Yes,
Yes. Okay. So any blood in your stool
no,
during passing stool? So
no,
have you? So do you have any acid test in your throat?
no,
Okay. So have you noted that your stool is difficult to be flushed out?
no,
No. So do you have any fever?
no,
Okay. So do you have any slime or mucus with your stool?
no,
Okay. Have you noted that this pain when you become anxious and it relieve with flatulence,
no,
with defecation also with passing stool?
no,
Have you been counseled for this pain before?
no,
So do you have any chest pain?
no,
Okay. Do you have any change in your eyes, or any dryness of your eyes or mouth?
no,
Any skin changes?
no.
So I will ask you about some social issue, personal. Uh, have you noticed that? Do you drink, please?
Yes, I drink
Yes. So how many units per week?
about 5, 6 units.
Yeah. Okay. So do you smoke?
No,
What's your occupation, please?
um, I'm still a student in
What?
university. I'm a universal student. University
University
student.
student.
University.
Yes. Who is living with you at your home?
My father and mother.
Father and mother. Yeah. Any family member has like this before this issue?
No, I don't know.
Okay. So do you have any regular medication? Do you receive?
No,
Okay. Do you have any medical condition for which you receive any medication?
no.
Okay, can you present
Any?
your case now?
Yes. Yeah. Thank you for your time. I will pass my notes to my consultant to figure out your issue. Okay. So if I have a time, I will take the history as regard the social history and also systemic review and the eyes.
Yes,
And before the surgical history also,
yes,
I took a history for Miss Jane, 19 years old, who presented with 1 day history of severe colic abdominal pain, rate 10 of 10. He
yes,
is all over the abdomen, referred to the back, no relieving factor. He didn't notice that.
yes,
She no related to special attitude or special food present all the time. Okay, associated with a change in the bowel and in bowel motion in form of diarrhea, 3 to 4 years, with no fever, no history suggestive of peptic ulcer disease, but she is alcohol drinker about 5 units per day. She hasn't any chest pain or cough or so on. So my top differential diagnosis will be acute pancreatitis, but also I will consider also other causes of acute abdominal pain with the same acute cholecystitis, ascending cholangitis, lower lobar pneumonia, pleurisy, and my lower myocardial infarction, but less likely due to the young age.
Yes.
So, as regards this,
how do you suggest to manage this patient?
Yes, as regard, I will start the acute pancreatitis. Will manage the patient according to CRIS protocol in form of ABCD approach to save IV fluid. But I will order also airway breathing, circulation, diabetes, and exposure. I will order some investigation in form of full blood count, serum amylase lipase, electrolytes, EBG, serum calcium, LDH, all parameters of Apache score and Ranson's criteria, and open which I will manage the patient. I will also order some investigation 48 hours after management of the patient, and I will consider give the patient IV fluid. Also give the patient somatostatin to decrease pancreatic secretion, proton pump inhibitor. If there is hypocalcemia, we'll give the patient replacement of the calcium, and will for also the any renal impairment. If the patient deteriorating and there is possibility of hemorrhage, I will consider surgical treatment in form of development of abscess or hemorrhage or more necrosis more than 30 degree. Or if the patient further developed pseudopancreatic cyst, I will consider also intervention radiological drainage or drainage surgically in form of cystogastrostomy or duodenogastros.
All right. Okay. Thank you so much.
Thank you.
Bell is gone. Now I want to discuss with you. It was very good. It's improving. What are the 2 essential questions that you could have asked this patient in this, considering this history, and you forgot to ask?
About cholecystitis?
No, about the history of weight loss, if any, and appetite. And if patient has traveled recently abroad or anywhere.
Yes, for gastroenteritis, yes.
Right. And another, considering the young age of the patient, what do you suspect should be your first top priority differential diagnosis? And here, it's like patient only had 2 episodes of loose motions. There is no history of drinking, and patient is young.
Yes, inflammatory bowel and irritable bowel syndrome.
First, more common is irritable bowel syndrome, and then irritable inflammatory bowel disease. Also, you will consider. Then you can also consider gastroenteritis or colon cancer. Or here, acute pancreatitis does not seem to be the fit, but considering it Western culture, because you are giving exam for UK and UK is West, even in the age of 19, he can present with first episode of acute pancreatitis. But then, like the history you took from your patient, you categorize leaning forward relieves, and it's from scale 0 to 10, it's 10. Like with that history that you got, yes, acute pancreatitis makes sense, but not otherwise.
Excuse ma'am, I want to add something that from the first impression, I suggest that the patient is inflammatory bowel disease due to tummy pain and change in the bowel habit in form of diarrhea. But the sequence of the response to the result is only sudden pain and without extra intestinal manifestation, and referred to the back. And this is away from inflammatory bowel disease. Inflammatory bowel disease is middle age. Chronic pain at least from 3 to 6 months. Loss of weight with a change in the bowel habit with extra-intestinal manifestation, at least skin changes, dry eye, mouth
Yeah.
ulcer. So it was distracting for me.
Yeah, that's right.
I lost at the
Track,
middle of the
yes.
station.
Uh,
So yeah,
And the
but
IBS can
always
be
remember what you read outside the bay, that is your question. You go inside, and if the patient tells you another story, you're not going to change your story. Like, you can't base it on what patient is telling you. You have to base in 1 minute when you're reading outside the bay. So whatever is written there, you have to ask questions according to that only. So that,
IBS can be severe pain, sudden pain.
yeah, young patients can present with all possible symptoms.
but the pathognomonic complaint is this pain is completely relieved by defecation, that by
Yeah,
passing
like
through.
this is what you got to hear first, and then you statement got changed.
Yes, yes, yes.
But
So
IBS can be a sudden abdominal pain. IBS, inflammatory bowel syndrome.
but
Inflammatory bowel
without,
disease, yes, but not
Irritable?
irritable bowel, not irritable bowel syndrome.
but
But
no,
sometimes, you know, considering female patient, female and teenager, attention seeking, anything can happen. Like, she can present like this as well. Underlying cause can be different, can be something else. Broke up with boyfriend, or got rejected by parents or something. So you'll come to see these sort of cases.
Okay.
Yeah.
yeah, the other thing, but this is not excuse. I always expect that the station will be pseudo aneurysm, but not excuse. At the exam will be shock station, not prepared just before, but is not excuse. I know that it is eligible to be shocked with the station at the exam.
Yeah, but the
Yeah.
more you'll practice, the more you'll become better.
Yes, yes.